So I'll start with the very basic things. That's the thing. And I won't spend much of time in the introduction part, right? So I'll be very quick here. And then we'll be spending more time in discussing the approach and discussing some of the scenarios as well. Okay. So this exam is OSCE exam, right? Objective, structured, clinical exam. So it's not like an exam that you have given in your life. I mean, mainly we give theoretical exam, or you might have given like say MCQ like your club one. But this is a different exam where you are actually going to talk. You have to talk for 3 hours. Why? Because you'll have 16 stations. Each station is of 8 minutes, and you'll have the professional simulators, those who are playing the role of actors, right? So you have 16 different patients, right? And each station, with each patient, you're going to get 8 minutes. Okay. And then what happens is there's a task outside as well. You'll get 1 minute and 30 seconds to read that task. What kind of task they give it to you? I'll just show you in the next slides. So I can say for one station, it roughly takes 9 minutes and 30 seconds, right? 8 minutes inside the cubicle and then 1.5 minutes outside the cubicle, right? And you have got 2 rest stations as well. So in total, you can say 16 station where you'll have the patient plus 2 rest station you will have. And each station is going to take 9 minutes and 30 seconds. So that is why the exam is going to take roughly 3 hours, right? So number one thing, do not think it's easy to talk for 3 hours. It's a very challenging part, I would say, because you have to be in your senses. You have to have full concentration as well. So be careful. Do not get tired before the exam starts. What we have seen, what we have heard from the candidates that when they go for the exam, they start practicing before the actual exam starts. So just practicing amongst themselves. Don't do that because when actual exam starts, you actually start feeling tired. So you need to be very, very careful about that. In the exam, you're not allowed to carry your watches and there won't be any clock as well. So now you're talking to the patient and you have got 8 minutes. How are you going to get the idea about how much time is left, how much time has gone? So no watch, no clock. But what happened is there is a bell system. There is a bell system. So what happens with the bell? So when you're standing outside the cubicle, after 1.5 minutes, there will be a bell saying begin. Begins means you enter into the room. When you go in the room, you'll have an examiner and you will have a patient. So your first interaction is going to be with the examiner. So what you do, you just introduce yourself to the examiner. Hello, my name is Ankur. And they will give you GMC batch number here as well. A batch which will have your name, your GMC number, and a number from 1 to 18. Why 1 to 18? Because you have got 16 station plus 2 rest station. So in total it is 18. So 1 to 18, there will be number for you. For example, you got number 5. So you'll be standing in front of room number 5 as your first station. So that's how it works. So after 1.5 minutes, you enter into the cubicle and the first interaction is going to be with the examiner. You tell the examiner, I'm Ankur, my GMC number is, you can read it from here, 1, 2, 3, 4, 5, 6. Examiner will have their iPad and they will just check if they are marking the right candidate. What they will say, doctor, you can proceed. So then you will proceed and you will start talking to the patient. So how much time you have got when you're talking to the patient? You have got 8 minutes. So what happened is after 6 minutes, there will be a bell saying 2 minutes left. And then there will be another bell after complete 8 minutes saying move on to the next station. So this is how it works, right? So no watch, no clock, but the bell is going to give you a bit of idea, right? So my suggestion would be whenever you practice any station, whenever you practice any station, any scenario with anybody, you have to do with the timer, right? There is an app as well, Clap to app. You can download it, or we have got GMC timer as well that I can send in the WhatsApp group. So no worries, if you're in the WhatsApp group, we will share it there. Okay. Let's move on. So what kind of stations that we have got in the exam? So we have got history scenarios, history from all the departments, I would say medicine, surgery, gynae, pediatrics, psychiatry. Then we have got some counseling stations. We have got ethical scenarios as well. We've got examination, mannequins, teaching. We have got SimMan, we have got prescription, and then we have got tele or video consultations as well. Okay, so all these scenarios that we have got. Now, see, GMC has not given us the breakdown like which department, how many scenarios. They have not given it like this. I can give you a rough idea. Prescription. So they usually give one scenario from prescription. They usually give one scenario from SimMan. They usually give two, examination or mannequins or teaching. So two of these. This part is very important. So roughly they give 6 scenarios from here, maybe 3 from counseling, 3 from ethics. This is very important part here. And so 6 to 8 and 10, and then roughly 6 scenarios from history. I would say maybe 2 from medicine, 1 surgery, 1 gynae, 1 peds, 1 psych. So this is how the rough I estimate I'm giving it to you. I'm not saying this is what they're going to follow all the time, but yes, it's a rough idea. This is what they do, right? So history, counseling, ethics, examination, SIMMAN, prescription. Now you'll have 1 or 2 tele consultations as well in the exam. 1 or 2, tele or video. Tele means you are talking to somebody on phone. And video, you'll have a phone, plus you'll have a video as well in front of you. So that's video consultation. After COVID, when they started the exam, they used to give us so many tele or video consultations. But now, obviously, no COVID, all the COVID restrictions are off. So what they are doing is they're giving less of these. So hardly 2 or 1 or 2 you will get. And these 1 to 2, what kind of scenario they're going to give you as teleconsultation? They can give you history, they can give you counseling, they can give you ethics as well. Obviously, examinations in my prescription, they can't give you as a tele or video consultation. So any history, any counseling, any ethical station can come as a tele or video consultation. How we are supposed to start the teleconsultation, there's a little bit of difference there that I'll cover in the introduction part. Okay, let's move on. So when you get the result, you get 2 sheets actually. So you get, this is the 1 sheet. So it has the marking. Each station, so you've got 16 station as we know. Each station is of 12 marks. Each station is of 12 marks, so which makes it roughly 192, right? In these 12 marks, we have got 3 domains. We have got data gathering, that is maximum of 4 marks. We have got clinical management, which is maximum 4 marks. And then we have got our interpersonal skills, IPS, that is also of 4 marks. So in total, it becomes 12 marks. So this is how it is. So 12 marks each, and we have got in total 16 stations. So that makes it 192 total score, right? So this is what happens. So every station, 12 marks. Yeah. Now, what we have to do to pass this exam? What you have to do to pass this exam? So number 1 is you need to get above the average score. Get above the average score. Now, what is going to be the average score? So it is going to be different on different days. For example, in PLAB 1, every 3 months your PLAB 1 happens, and what happens is, what's the passing score? It's different every time, right? It's different every time. So same thing in PLAB 2 as well. Every time it's going to be different. So if you ask me roughly how much we are having, it's roughly, I would say, 110 plus minus 5. So that is a roughly passing score. So what you need to do, you need to get above the average score. An average score is going to be different on daily basis. Now, out of 12, how many marks I get so I will pass the exam? There is nothing like that. For some station, it might be 6. For some station, it might be 7. For some station, it might be 8 as well, right? So different station, different passing score, different exam, different average score. So this is one. Another thing, in November, till November 2024, they used to have another criteria which says you have to pass 10 out of 16 stations. But that's the old criteria. They used to say that you have to pass 10 out of 16 station as well. So you have to get above the average score, and you have to pass 10 out of 16 station. When both the criteria are met, you pass the exam. Now, the new guidelines, the new criteria says, number 1, you have to get above the average score. But number 2, they are not saying you have to pass 10 station. They have said for every exam, we're going to decide how many stations you are supposed to pass. For every exam, we will decide. So that is the thing, right? So for some exams, it might be 9 stations. For some exams, it might be 10 stations. For some exams, it might be 11 stations as well. But to be honest, those who have got the result after that, they have said it is really good. Even most of the times, even if you are passing 9 stations and getting above the average score, we are passing the exam. So this is better, I would say, not worse. But yeah, so you have to have these 2 criteria. Number 1, get above the average score, and number 2, pass the minimum number of stations, which will also be decided on that particular day, right? Another thing is a skill area. So they are actually marking us on these 10 skill areas. Number 1 is your consultation, your diagnosis, your examination, findings, issue, language, listening, management, rapport, and time. So they're marking us for these 10 things, right? So what happened is They will give you these ticks as well. Sometimes they write you as well. So ticks are not good. Even if they write you, that's not good because that means unsatisfactory. So what I mean by this, so if you see station number 16, so station number 16, there is a tick here. It means the consultation was not up to the mark. For station 15, you'll see there's a tick here, there is a tick here, there is a tick here. So examination, findings, and listening, there are ticks. It means these three domains are, these three skill areas are not done properly for that particular station. Okay, this is how you get the result. Now let's understand these skill areas quickly. Right. So consultation, what do we understand by consultation? It says smooth consultation. What I mean by that? So there is a pattern when you take history. Yeah. So what you have got presenting complaint. You do elaborate the presenting complaint. You go to differentials, associated symptoms. You go for past medical history. You go for lifestyle history. You go for social history. So what do? You follow a pattern. So make sure you always follow the pattern. Okay. If you're jumping here and there, if you're doing unstructured consultation, which is of no logic, then you will get a tick in consultation. Okay. Right. Issues. Recognize the issue. So if I ask you a question, if you got a patient, are you going to do medical treatment first or non-medical treatment first? Answer, guys, in the chat box. You got a patient, are you going to do medical treatment first or a non-medical treatment first? Somebody said medical. Somebody said it depends. Somebody said non-medical, medical. Okay, depending on the case. So answer is it depends on the scenario. You cannot just generalize that I'm going to do medical treatment first or I'm going to do non-medical treatment first. If it is a diabetic station, hypertension, high cholesterol station, patient has come to you first time, so maybe you are going for non-medical treatment first. But if your patient is like struggling to breathe, his saturation is 80, it is an acute exacerbation of asthma, and you're saying don't smoke, don't drink alcohol, it doesn't make sense, isn't it? So what you have to do, you have to go for medical management first, right? If retinal detachment, what medication we do? Like, what do you mean? If retinal detachment, what medication do we give, for example? So for retinal detachment, what you can give? You can't give any medication. There is no medication. But are you going to refer this patient to the specialist urgently? Yes. And they'll be able to manage the patient there, right? So this is how it works. So medical treatment or non-medical treatment. So this is how we have to go about it, right? So for retinal detachment, obviously, doctor, you refer the patient. There is no non-medical approach that's gonna work there. I meant like in this case of retinal, no medical treat, for example. It is surgical. Yes, that's fine, doctor. So medical, okay, you want to put it in this way. Medical or surgical treatment or non-medical treatment. Let's put it in that way. All right. Time. So time is, what we have got is we have got 8 minutes, right? So we have got total 8 minutes for each station. Now you have to have three things. You have got data gathering, you have got management, you have got IPS, right? So how you can divide your time? The thing is, a lot of candidates, they think I've got 8 minutes and I've got a bell after 6 minutes, right? So they're spending 6 minutes in history and then spending last 2 minutes for management. Do you think it's a good idea? I would say it's a really bad idea. The thing is, management is 4 marks, data gathering 4 marks. Please do spend equal time. So I would say 4 time for your data gathering, 4 minutes for your data gathering, 4 minutes for your management. That's what you have to do, right? And then obviously IPS is how you're going to make the patient comfortable and all. So that's going to be there throughout. But for history, do not go beyond 4 minutes or maximum 4.5 minutes. The candidates, those who failed the station, is only because of management. It doesn't mean they don't know the management. They know the management, but they don't have enough time for the management. Why they don't have enough time for the management? Because they're spending too much of time in the history. So you have to be very, very careful on this part. Okay. Findings. Obviously, our job is to find abnormal findings. So they will give you lots of abnormal findings on history. They'll give you lots of abnormal findings in examination and on investigation. So make sure you interpret it well. Okay, then examination, in whichever station they're expecting us to do the examination, make sure you do proper examination, right? And whichever instrument they have given it to us, you use them, handle them, hold them proficiently, right? Diagnosis. So what do you think? Will you be able to make the diagnosis in all the stations? Yeah. What do you think? Yeah. Okay. During history station, do we need to write any notes or any verbal communication with the patient? Doctor, you don't get pen and paper, unfortunately. So there is no pen and paper. Even if you want to write, you can't. So whatever you're writing here in your mind. Okay. So no pen and paper is given in the exam, right? So diagnosis. Will you be able to make the diagnosis in all the stations? So will you be able to make the diagnosis? So what happened is, uh, if possible, yes. If possible, yes, of course, we can give the diagnosis. But if you are not able to make the diagnosis in the exam, then what's going to happen? What you do in your clinics, what you do in your clinics when you don't have the diagnosis. What you do is you go for examination, you investigate the patient accordingly as well. So if you don't have the diagnosis, you have got a couple of differentials in your mind, and accordingly you investigate the patient. And then once the investigations are back, once you're done with the examination, then maybe you're able to get the diagnosis, right? So this is what you have to do in the exam as well. You may not be able to make the diagnosis, and that's not going to make you fail or pass, to be honest, right? So you have to have a good history skills. In real life also, as a doctor, I can't make the diagnosis with every patient, right? So this is what you have to do. In the exam, if you somehow can show it to your examiner, I'm a doctor, you will pass. But if you are behaving like a medical student, you will not pass. As simple as that. So as a doctor, when I'm sitting in my clinic, I can't make the diagnosis all the time. So what I've got, I'll tell my patient that I've got these two things or three things going on in my mind. You gave me that history, which is taking me towards this diagnosis. You said this thing as well, it's taking me towards other diagnosis. And you said this as well. So I'm not very sure, to be honest. I'll be very honest with you. But what I'm going to do now, I'm going to investigate you further. I'm going to do this investigation. And meanwhile, I'm going to give you some symptomatic treatment. So that should be your diagnosis and management plan, right? So don't panic if you're not able to make the diagnosis. Try ruling out differentials, try ruling out red flags. That should be enough. Okay. Now, GMC says management plan must include follow-up and a warning sign. Management plan must include follow-up and warning sign. So, whenever doing the management, so last few seconds, I would say last 20, 30 seconds, you have to keep for the follow-up and warning signs only. So keep that in mind. That is really, really important. So follow-up and warning signs, right? So when you practice with the time, what happens is when you're practicing with the timer, you will automatically, after you practice 5, 7, 10 station, you will automatically have an idea, okay, last 30 seconds left. Now what is my job? I have to mention about follow-up and warning sign. Now a lot of candidates ask me, doctor, can I do this follow-up and warning sign when I'm starting my management? My answer would be no. Follow-up and warning sign is the last thing that you will do in your station. All right. Then you've got rapport. Rapport is make your patient comfortable. Now, how are you going to make your patient comfortable? That's a very vague statement, I will say. Make your patient comfortable. So, would you like to say in the chat box, what can you do to make your patient comfortable? Tell me what you can do to make your patient comfortable. So, yes, tell me. Sympathize, okay. Use their name, okay. Empathize with the patient. I'm here to help you. Okay, okay, okay. Right. So if my patient is in pain, tell me, is it a good idea to say sorry for the pain, or you don't want to say sorry? Nodding and active listening. Good. So if your patient is in pain, should I say sorry or not required, or you don't want to say sorry? It depends. Okay, not required. Okay, sorry, you are going through this. Okay. So I got all three, four answers. Yes, no, maybe. That's nice. Okay. So yes, I would take this one. That's nicely written that it depends. Yeah, it depends, I would say, on you, right? And in the UK, those who are in the UK, I think some of you might be attending from your countries, and obviously you're going to come for the exam in the UK. Those who are already in the UK, you might have observed one thing that uh, here, for everything they say, please, kindly, sorry, thank you. These are kind of very common things, right? So there's no harm in saying sorry. But the thing is, whenever you say sorry or thank you to somebody, you need to specify why as well. If you say somebody, thank you, that's not enough. If you say, thank you for sharing your notes with me, that is good. That is what is advanced communication is, right? So whenever you say sorry or thank you, you have to say why as well at the same time. So when you're saying sorry, you can, but whenever you say these things, you have to say it with your heart. I'm so sorry to hear about your pain. Are you comfortable to talk? So that's okay. But some people, they just say, I'm sorry, tell me more about your pain. Don't do that. This exam is emotional exam as well. This exam is like communication exam as well. This exam is about presenting yourself nicely, right? So saying, uh, I'm sorry for your pain, it's entirely up to you. Make sure you are soft spoken, and whenever you say sorry, it should come from your heart, right? And you have to say sorry for your pain, right? Not like, I'm sorry, tell me more. No, I'm sorry to hear about your pain. You have to complete the line. That is really important. Okay. Fine. So, what else we can do to make the patient comfortable? Make sure you listen to the patient carefully. Now, we know, like in our countries, those who are working, say, in a government setup, you don't get enough time to talk to the patient, and we don't let the patient talk that much. But here, you make sure you listen to the patient carefully. So, you're a good listener. And if you see patient is talking a lot, what you can do, I think somebody mentioned as well. So, what you can do, you can just nod your head as well, right? So, it means if you're nodding your head, it means you're a very good listener as well. So, you're spending 8 minutes with your patient. In those 8 minutes, you have to somehow prove that I'm here to help you, and these 8 minutes are dedicated to you. So your whole body should talk. You should have that thing in your head, like, yes, I'm here to help. That enthusiasm you have to have. I've seen some candidates when they do the consultation, they're very much relaxing, not at all bothered about the patient. They're like, yeah, tell me more about pain. Okay, what else do you have? This is not the consultation is. So when you talk to somebody, you have to be sitting very comfortably, right? And have a bit of smile on your face, very attentively, not like very dull posture I'm sitting. No, very attentively I'm sitting. I'm using my hand gestures to explain as well. I'm modulating my voice. I'm having a lot of facial expression as well. And it's not only talking from here, my whole body is talking. So that is what a nice, proper consultation is gonna be looking like. Okay, so be careful about these things, right? If you can somehow show it to the patient that I'm here to help you, and they got that thing from you, the examiner is going to give you better marks, right? Listening, make sure you listen to the patient carefully and you pick verbal and non-verbal cues as well. Verbal is obviously patient is telling you, I'm having cough, I'm having nausea, I'm having vertigo. They're telling you, but there are lots of things they won't tell you, they will show it to you. So what you have to do, you need to pick those non-verbal cues as well. So for example, patient is sitting and shaking his leg. So the thing is, if somebody is shaking their leg, there is something there. You need to acknowledge it. So whatever they do in the exam, there's a reason behind it, right? So if you see anything unusual in any station, if you see anything unusual in any station, what you need to do is you need to acknowledge it. If you see somebody shaking their leg, you say, I can see you are shaking your leg. Is everything all right? Is there anything I can do for you to make you more comfortable? Say it, anything unusual you see, just stop in the history and you say that thing. You may see like, okay, in one station, your patient is coughing. All right, doctor, yeah, I'm not feeling okay. It's just like, I'm having pain in my leg. But this patient is deliberately doing this coughing. What does it mean? And you're like, yeah, it's something like in between he's putting it. So you need to acknowledge, I can see you are coughing, Michael. Is everything all right? Is there anything I can do for you? Do you need a glass of water? Do that thing. Do that thing. So that is really, really, really important. Do not miss that part. Okay. Recently, domestic violence came in Plaptu. She was having insomnia, masked and domestic violence. She was on phone call. So how we see the gestures to offer confidentiality. I'll talk about that, doctor, in a telephonic consultation, right? Telephonic consultation, it comes with lots of challenges as well. Don't consider it's easy, right? As you said, how will I see the gestures? You can't. But what you'll have at least the tone of the voice of the patient. With that, you need to get a bit of ideas, right? It's not going to be easy. It's going to be challenging. I have that scenario in my list as well, the insomnia, domestic violence. We'll have a discussion on that. Language, make sure you use the language or explanation that are relevant or understandable to the patient as well. That's really important, right? So do not use medical jargons. You're talking to whom? You're talking to a I mean, a normal person is not a medical doctor, isn't it? So what you have to do is use the language or any explanation that is in the normal layman language. Okay. So these are the things that you need to be very careful with. What kind of task you're gonna get? This is how you're gonna get the task in the exam. So candidate instruction. And this paper you'll have outside the cubicle that you're gonna read for 1.5 minutes. The same paper is gonna be inside the cubicle as well. So if you wanna read it again in the cubicle, that is absolutely fine. You are, sorry, where you are, who the patient is, other information about the patient, what you must do, and a special note, right? All five stations are divided into these five headings, right? And to be honest, when it is divided into five headings, it makes your life easy to understand it as well. Yeah. So it says you are foundation year 2 doctor. So in every station you will see you are FY2. What is this FY2? Foundation year 2 doctor, which simply means you are an intern. You are in an internship. Now tell me honestly, how much do you know as an intern? I knew nothing when I was intern, right? So they're not expecting very high-fi things from us, but what they want that we are a safe doctor. They're looking for a safe doctor. Because at this level, as an FY2 level, I cannot be the multi-specialist. If I know everything about medicine, surgery, gynae, pediatrics, psychiatry, then I'm not a human being, I would say, right? And as an intern, we know limited stuff now, right? And in every station you will see, you will be FY2. FYG doctor in rheumatology unit. Now the question is it important? Is it important to know which department I am in? Yes, it is really important, right? Because if I'm in the GP, my management would be according to that. If I'm in A&E, my history, my management will be according to that, right? So it's really, really important. I heard these tasks are coming longer and more information. Yes, doctor, I just showed you a sample task, right? And you know what happened is when it is counseling and ethics task, the information given to you in the question is quite too much, I would say. I'll show you those tasks as well. But when you have got a history station, you won't have much things in the question, right? So Jan exam had short lines only. See, again, doctor, we can't generalize. I'll tell you, if it is a history station, you'll have just one line. If it is a counseling or ethical station, they will give you a bit more information. So that's how it works. So it's going to be a mixture of both. Some are just one liner, some are a bit more, right? So you are in the rheumatology unit, you are in the GP, so it's gonna be different, right? So you have to be very careful on that. For example, if you are in the GP, now tell me, can you admit the patient in the GP? The answer is no. Can you keep the patient for observation in the GP? The answer is no, right? So if the task says you are FY2 in the GP and the management, you're saying, I will admit you here. So it's not going to make much sense, right? And in the GP, what are the investigations that you can do? You can do some blood tests. You can do urine test as well. In blood test, I mean, you can even check vitamin levels as well. Yeah. What else you can do? You can do ECG as well. Right. So now my question is, can you do troponin in the GP? Can you do the troponin in the GP? The answer is no. If as a GP you feel like doing troponin, that's not your patient actually. That's not your patient. So what you have to do is you have to send this patient to the hospital, right? Now, can I do X-ray, ultrasound, CT scan, MRI scan in the GP? The answer is no. But remember one thing, as a GP, you can actually order one. So for example, patient came to you and you want to have an ultrasound done. You can't do it in the GP surgery itself, but you can tell the patient, I am arranging an ultrasound scan for you. So what's going to happen? You're going to get a call or a letter from the hospital, and then they will give you the exact time and date, and you go to that hospital on that day. They will do the ultrasound scan, and the report will be sent to the GP. GP will see the report, and they will call you. If it is normal, they'll say it's normal, and if there is something there, they'll call you again, and then they can discuss the reports with you. So this is what exactly happens, right? So if you ask me, can I do ultrasound, CT, MRI in the GP? No. Can I order it? Yes. So this is something very important. Yeah. So you can't admit the patient, you can't keep the patient in observation as well in the GP. Yeah. So your foundation here in rheumatology unit in A&E GP, that's very important. What they give you the name of the patient, Mr. Stanley Smith, age 45, was referred from the GP with the pain in the right big toe. Now you see if they have given you this much of information, pain in the right big toe, what comes in your mind? Tell me in your chat box, guys. Pain in the right big toe, what comes in your mind? Gout, as simple as that. Excellent. Gout, yeah. So this is gonna give you a bit of idea. But sometime what they do is they give it very simple way. Stanley Smith, age 45, has been referred by the GP because of some problem. Yeah, like which problem? Some problem. So they're not giving us much information as well, right? So it depends. I mean, sometimes they give a bit of information, sometimes they don't, right? Now, other information. Sometimes they say none, but sometimes they might give you some extra information as well. For example, if I say patient is fond of eating steaks, the patient is fond of drinking beer, patient is having high blood pressure and taking thyroids. Tell me these three things, are they important or not? Are they important or not? They are important, right? Because all these are the risk factor. So sometimes what happens is they might give you some risk factor in the question itself, but sometimes they don't give it to you, so you have to ask to the patient. So this is how it works in the exam. So sometimes in extra information they'll give you something, but sometimes they'll just say none, no extra information. All right. And then what you must do is talk to the patient, assessing. Whenever you see the word assess, wherever you see the word assess, what you do is you have to do history and you have to do examination as well. Now the question comes is, am I going to do examination in every station where it says assess? The thing is, you may not be doing the examination, but you have to mention. When you say, I would like to do this examination, sometimes the examiner will give you the findings. But sometime when you enter into the room, you see there are some instruments, some mannequins are there. So what does that mean? It means they're expecting you to do the examination as well. So it may not be very clearly written in the question whether they want you to do the examination or not. What will be written? It will say always assess him. But assessment means history and examination both. Am I going to do it or just going to mention it? I will see when I enter into the cubicle. If I've been given some instruments and all, I will do it. If I've not been given anything, then maybe I'm just mentioning it and then examiner might be giving me the finding. That's how it works. And then discuss the management with the patient or with the examiner. Please check the task if they want you to do the management with the patient or with the examiner, right? Most probably 99% is going to be with the patient, right? And then spatial note. Spatial note can be none. Spatial note, patient is worried, patient is angry, right? Sometimes when you are not talking to the patient, that's very important. When you're not talking to the patient, you're talking to third person, maybe the husband, wife, mother, daughter, whatever. So you need to have a line in the spatial note that consent has been taken from the patient. That's really important. If you do not have the consent from the patient, if you do not have the consent from the patient to talk to the relative, you can't give any information to them, right? This is very, very important as well. So that's why this is spatial note, right? Okay. Now, how are you going to start your history? Let's go about it. So, you enter into the cubicle, your first interaction is with your dear examiner, then you'll start approaching to your patient and you greet them with a smiley face, yeah? Trust me, a smiley face can do wonders in this exam, right? Don't underestimate it. Again, there's a difference between smiling and laughing. I'm not saying you to laugh on your patient's symptoms. I just said enter into the cubicle with a smile. When you give a smile to somebody, they actually feel, yeah, this doctor looks confident, isn't it? But if you are not smiling enough and all, it might not be a good idea. So have a bit of smile, that definitely helps. In every single station, you have to make a habit that you have to introduce yourself and you need to identify your patient details as well. What if it is seen as a fake smile? It might backfire. That's why, doctor, we say to practice, isn't it? Why? This exam, we always say that after the course and all, whichever course you do, you should have at least 6 to 8 weeks for practice as well, right? So in the practice, at least you'll be able to learn those things, right? So yeah. This is an acting exam as well, so that's what we say 6 to 8 weeks. Try learning a bit more as well, right? I know, like in our countries, most of our countries, nobody bothers like how's your facial expression, how's your tone of your voice. And as a doctor, our tone of our voice is a bit firm, especially the gentlemen's. Our tone is a bit more firm as well. Uh, Work on those things, right? This exam is not only medical exam, it is medical, it is communication, it's how you present it, right? Plaptu is not what you say, it's how you say things. How you say in your language, how you say in terms of your expression as well in those lines. So that is really important, right? So I know like it might seem a fake smile, but then if you work on it, it's going to come genuinely as well. Another tip I can give it to you is please practice in front of the mirror, right? Those who have this doubt that I might sound or I might smile like it's looking like a fake smile, practice a station with yourself daily, at least one station. And in 10 days or so, you will see the difference in you. You will see now this smile is coming and it's not fake as well. So this is how we learn, right? That's the main idea. Okay. So in every station, what you do is you introduce yourself and you identify the patient details. See, the name and the details of the patient will be given to you in the question. Can I use this information? Of course, you can give that information, use that information, not a problem. So if I have to introduce myself, I would say, hello, I'm Ankur, one of the doctors here. I've seen a lot of doctors, they are introducing themselves saying, hello, I'm one of the junior doctor. You don't need to say junior, senior, simply, hello, I'm Ankur. Have a smile as well. Hello, I'm Ankur, the doctor's here. May I get your name and age, please? Right. Or you can say, are you Mr. Stanley Smith? Yes. How would you like me to call you? You can call me Stanley. Hello, Stanley. Nice to meet you. How can I help you today? So that's how you're going to start your scenarios, right? So your introduction and the identification of the patient is must, right? So identification, are you going to use the information given to you in the question? Or you're going to ask it again? It is entirely up to you. Make one thing and do similar thing in all 16 stations, right? So if I have to start the station, this is how I'm going to start. Hello, I'm Ankur, the doctors. May I get your name and age, please? Hello, doctor. I'm Stanley. I'm 45. Hello, Stanley. Nice to meet you. How can I help you today? That's it, right? Another thing, just remember one thing as well. For example, your patient name is Mr. Stanley, Stanley Smith. So when they say I'm Stanley, you go with Stanley only. I've seen sometimes patient says I'm Stanley, and you say hello, Mr. Stanley, and they're like, no, Stanley is fine. Hello, Mr. Stanley. No, Doctor Stanley is fine. So this Mr. it will not go with the first name. It is Stanley or Mr. Smith. It is Stanley or Mr. Smith. So this is how we have to go about it. Some prefer date of birth instead of age. This is up to you, doctor. Whatever you prefer, this is entirely up to you, right? Can we introduce doctor last name? That's fine as well. That's fine as well. No problem at all, right? Okay, but make one fixed thing and do that in every station. Don't try, okay, I'll say something in first station, something else in the second one, something else in the third one. Don't do that. Because in all 16 station, 16 different examiners are sitting. So you don't need to change the way you start the station, right? Does that make sense? Yeah. And then you start, what brings you to the hospital? How can I help you? And then patient will start talking to you. Okay, done. So what you do in the history, so you have got presenting complaint. Then what you do elaborate the presenting complaint. Then you ask some associated symptoms. Then you rule out some differentials as well. Then you go for past medical history, you go for personal history, then you go for social history. So this is a rough idea, a rough estimate. This is how you're gonna go about your history taking. Right. Now, guys, tell me if you are ruling out differentials, what do you think? How many differential I should rule out? Tell me. How many differentials in a station I should rule out? What's your understanding on that? 4, 5. relevant, about three, three, four, the dangerous ones. Okay, good, good. 3, 4. Okay, I think 3, 4, 5, that's enough. And it depends on scenario to scenario as well. See, if your diagnosis is the dangerous one, let's put it in this way. If the diagnosis is a dangerous one, you don't have to rule out many because your diagnosis is dangerous one. However, if your diagnosis is something simple, then you have to rule out all the dangerous one. Let's put it in this way. If you have got subarachnoid hemorrhage as your differential, if you as your diagnosis of headache, in subarachnoid hemorrhage, this is what you think is your diagnosis. You don't have to rule out so many differentials because SCH is an emergency. However, if your diagnosis is coming out like tension headache, it is simple one, right? But then you need to rule out all the dangerous ones. That's how it works, right? However, if you elaborate the presenting complaint nicely, you will be ruling out lots of differentials already. You don't have to do anything. For example, let's put it in this way. Uh, okay, I'll come to this. I'm coming back to this slide. So presenting complaint could be pain, presenting complaint could be cough, could be shortness of breath, it could be fits, fall, loss of consciousness, dizziness, vertigo. So that can be your presenting complaint, right? So how are you going to elaborate? If it is pain, we have got Socrates. If you got cough, shortness of breath, we have got Odipara. And if it is fits, fall, loss of consciousness, we have got history in before, during, after. Right. So Socrates, every single thing has got a meaning. Site is important. Onset of pain is important. Character of the pain is important. R is radiation is important. Associated symptoms are important. Time is important. Exacerbating and relieving factors are important. And the severity of the pain is important as well. So everything, every single thing is important, right? Now, what I was saying about differentials. See, how are differentials we're ruling out? See, if you elaborate the presenting complaint by doing a proper Socrates or proper Odipara, you will see you have ruled out so many differentials already. Let's take an example. You have got, guys, a female patient, say 27 years. She has got pain in right iliac fossa. Right iliac fossa, guys, pain, right iliac fossa, a young female patient. Can you give me the differential? Please give me the differential. Young female, pain, right iliac fossa. Give me the differentials. So I got appendicitis. Let me write it here. Ectopic PID, ovarian torsion, UTI. Okay. Ovarian abscess. Yeah. Anything else? Anything else that I missed? No, I think I've written all the things that you guys have mentioned. Any injury? Okay, trauma. Let's put it as trauma, doctor. Or you said stone. Okay, kidney stone. Yeah, fine. I think that's enough, right? I think these are the most common ones as well. So patient started, doctor, I've got pain in my, here, this area. That's what the patient said. Right. So what is going to be your next question? Peritonitis. Okay, let's write that as well, doctor. That's fine. So patient said, doctor, I've got pain here. How are you going to elaborate? Doctor, I've got pain. How can I help you? Doctor, I've got pain here. Next question. Ask me. How long? Wrong question. The question should be, tell me more about it. Guys, always don't go with the closed question. What is open question? What is closed question? Open question where you are letting the patient talk, and closed question where you are not letting the patient to talk. So what you have to go with, you always have to go with the open question. Whenever patient says, doctor, I'm having cough, doctor, I'm having pain, what you need to do, simply tell the patient, could you please tell me a bit more about it? Could you please tell me more about your cough? Could you please tell me more about your pain? Right? In the exam, if you stick to the basics, life will be easy. Life will be easy. Because if you have to do the full Socrates, how many questions are there? One, two, three, four, five, six, seven, eight. If I have to ask 8 questions, it might take more than a minute or two, isn't it? But if I say, tell me more about it, patient will tell me everything, maybe, and he's gonna save 1 minute of my time as well, right? So always tell me more about it. Okay. So doctor, my pain is here, and I would say it is a 5 out of 10, doctor, and it is a dull pain, and it started here and it is still here, so no radiation as well, and is there since yesterday. I'm taking a bit of paracetamol, which is quite helpful. So that's what history I gave. Anything else you want to ask in the Socrates? Ask me. Anything else you want to ask in the Socrates? Tell me. So this is the history I gave it to you. Anything else you would like to add in it? Sudden or gradual? Doctor, gradual. Anything makes it worse or better? Not really, doctor. It's just a similar kind of pain, 5 out of 10. Paracetamol helps a bit. Since when? It's started yesterday, doctor. It is continuous, doctor. Very good. Any time of the day it gets worse? Nothing, doctor. It's there all the time since yesterday. Fine? All right. I scored a doctor 5 out of 10. That's done, right? I scored it 5 out of 10. Now let's come back to our differentials. So I said it started here, it is still here. Can it be appendicitis? The answer is no. Usually appendicitis, what happened? The pain started from the umbilicus and then it's going to go to the side. So it is less likely to be appendicitis. And in this exam, I don't want you to use too much of yes, no. You have to be a bit diplomatic and try going with the words like unlikely, less likely, more likely. Yeah, so these are preferred words. Can it be a topic? Maybe yes, maybe yes. So I'll still keep it in mind. Can it be PID? Of course it can be. Can it be ovarian torsion, doctors? I said 5 out of 10. Do you think 5 out of 10 is fitting with torsion? I would say not really, not really, not really, right? So it's not fitting with this thing. Can it be UTI? Maybe. I'll still keep that in my mind. Can it be ovarian abscess? Maybe. I'll keep that in my mind as well. Trauma? Dull pain? Maybe. Okay, fine. Can it be kidney stone? Can it be kidney stone? I don't think so because kidney stone, first of all, it's not 5 out of 10. It's really bad pain. And I think there is radiation as well from, like say, from loin to groin. So it doesn't look like kidney stone as well. Can it be peritonitis? I don't think so. Peritonitis, 5 out of 10, dull pain. Its patient is going to be in severe pain again. So it doesn't look like peritonitis as well. So guys, till now, what point I want to make? See, I didn't try to rule out any of the differentials till now. I didn't try to rule out any differentials. What I did, I just elaborated my presenting complaint. That's what I did. And I was able to rule out 3, 4 differentials. Right? So this is what you have to do in the exam as well. I know I'm still left with 3, 4 differentials. I have not got my diagnosis yet, but I was able to rule out many of them. Now, so if the patient says, I'm in pain, what should be your next question? Tell me more about your pain. Tell me more about your pain. That's it. And patient will tell you some of these things. Whatever patient has not told you, then you can ask those questions and finish it off. Right? Then after that, what should be my next question? My next question is anything else? So you've got pain. Do you have anything else with the pain? Guys, these 2 questions, tell me more and anything else. If you ask to the patient, your life will be easy in the exam. Your life will be very easy in the exam. Okay, so anything else? So now, for example, my patient said anything else. My patient said, Doctor, I've been having some fever as well. Some fever as well. Okay, tell me more. Doctor, what do you want to know? Did you check it? What are you taking for it? How much was it, right? So patient said, doctor, it was not that much and I was taking paracetamol, so that's quite helpful as well. Okay. So with paracetamol, with the fever, it's going towards infection. It could be PID as well. It could be ovarian abscess as well, right? Fine. So after fever, what should be my next question? I will ask for anything else. And patient said, no, doctor, that is it. So now my differentials are still like it could be PID, it could be ovarian abscess. It could be UTI. And of course, I have not ruled out ectopic and trauma 100% as well. So my first question was pain. I did elaborate it. Anything else? He gave me fever. I did elaborate that as well. Now, when I asked anything else, he said no. Now, what you need to do is you need to ask associated symptoms to confirm your diagnosis. Plus, you need to rule out some differentials as well, which you have not ruled out. Now let's try doing that. So now what do you think which question I should ask? I've got many options here. It's not like I should ask only one. So I've got these four things. So patient started with pain here. So what I can ask, change in the urinary and bowel habits. That's a good question. So I can ask like, okay, if there is any change in the urine or bowel habits. Patient is like, what do you mean? So you can ask like, I'm looking for any diarrhea, any constipation, or any burning sensation in the urine. No, doctor, no, doctor. So if they say no, this UTI also seems to be out of my list. All right. Then what I'm gonna ask, I can ask for other questions as well. So I'm left with any trauma. So you can ask any trauma by any chance? No, doctor. Okay, trauma is out as well. So I'm left with these two, PID and ectopic. Fever going more towards PID. So what I can ask, young female patient, do you have any discharge coming from your vagina? Yes, doctor. Green color discharge. So what you do? Ask more question. What is the color of this discharge? Is it smelly or not smelly? How much was it? How many pads did you change? So those questions you can ask. So if patient said yes to discharge, so we are going more towards the STI PID. So you can ask more questions as well. You can ask for nausea, vomiting. What else you can ask? You can ask for like any ulceration in the private area, any redness, hotness in the private area. So all those questions you can ask. Now, my diagnosis is going more towards STI PID. So I'm supposed to ask sexual history as well. Sexual history as well. Now, the thing is, usually sexual history is a part of personal history that we usually ask in the end, isn't it? We usually ask in the end. Yeah. So now the thing is, should I ask sexual history here in the personal history or should I ask it here now? Because a lot of candidates they say that if I ask sexual history here, I'm gonna break my sequence of history taking. My answer would be no, you are not gonna break the sequence of history taking because it is too logical to ask sexual history here. If I delay the sexual history till this point, I won't be having my diagnosis properly. So you have to ask it here. Yeah, let me go back to this slide. So it says a smooth consultation. I agree. A big negative is if it is unstructured consultation, if it is illogical or disordered approach. So if I am asking a history question of personal history in the beginning, it is logical, then you can ask. So I've seen a lot of people, they don't ask sexual history here. What they do is they just ask sexual history here in this particular scenario. It doesn't make sense. It is logical to ask sexual history now because then only you can make the diagnosis of STI or PID, right? So what you do, you ask sexual history in detail as well. Now, when you do that, you got multiple sexual partner, unprotected sex. So kind of your diagnosis is confirmed here, right? Now, any differential that you feel we are left with? Yes, I'm left with ectopic pregnancy. I'll ask when was your last menstrual period? After 2 weeks ago. So that is out as well. I'm left with ovarian abscess. Okay, that's tricky. First of all, multiple sexual partner, that's going more toward STI PID. So if it is PID or if I'm thinking about abscess as well, I'm definitely in the examination investigation. I definitely want to do an ultrasound scan as well. Once I mention that, I will be able to differentiate whether it is abscess or not. Right. So did you understand a bit what I was trying to explain through these slides? In the last like 10-20 minutes, what I was trying to explain is we can't generalize how many differentials we are ruling out. We can't generalize it. So if you elaborate the presenting complaint nicely, half of the differentials you will be able to rule out then and there. And then whatever is left, you will try ruling it out in here in associated symptoms in differentials. Remember one thing, guys, do not go to past medical history. Remember, do not go to past medical history until unless you have got the diagnosis or at least two topmost differentials. That's what you do. And the most important question would be, tell me more and anything else. right? Let me show you a slide which has got everything. This slide. So in this slide, actually, I've tried covering everything in terms of history. So when you start a station, you start with how can I help you? And that is very much an open question, right? What should be the next question after that? Next question should be tell me more about it. That is open question as well. The patient says, I'm in pain. The next question is tell me more about your pain. Fine. Patient is going to elaborate whatever they have elaborated for you, that's fine. Whatever they have not said, what you do, you will complete your Socrates and Odipara by asking some of the close questions. Once you're done elaboration, the first thing, what should be the next question? Is there anything else? Is there anything else? If they've got any other symptom, what do you do? If there is any other symptom, what you do? You do elaborate that as well. So on the basis of elaboration of your first symptom, on the basis of elaboration of your second symptom, you'll have some differentials also in your mind. What you do? You will ask some associated symptoms to confirm your diagnosis, and you will rule out some important red flag, emergency, killer differentials as well, which you have not ruled out earlier. That's it. This part, these 4 or 5 lines, if you can understand properly, these 4 or 5 lines is what you need, to be honest. In history taking, tell me more, anything else. Tell me more, anything else. Tell me more, anything else. So this is very, 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 very important, right? Now, a few more things I will add before going further. So remember one thing, you will go to past medical history or personal social when you have your diagnosis with you. If you feel I have not gotten my diagnosis, I still have 5 differentials here. So what you do, you ask questions for all 5 differentials here only, and then only you will move ahead, right? Now, I'll give you some tips, tricks here as well. So many candidates they say, like, when I'm taking history, sometime I just get blank. I just get blank as well. What should I do? And sometimes the problem that patient has got, it is a systemic problem. So just with the elaboration of 1 or 2 symptoms, we may not be able to crack the diagnosis as well, right? Okay. So what you do is few things here. Number one is two of your best friend that you can use. Number one is your eyes. Second is your systemic review. What I mean by that? Systemic review. So what is ICE first of all? ICE. ICE is your idea, concern, expectation, right? See, the practice that you're doing in your country and the practice, medical practice that you have to do it in the UK is a bit of different thing actually. In this country, whenever a patient comes to us, we always ask them, do you have any idea what's going on with you? Are you concerned about anything in particular? Is there anything else that you are expecting from today's consultation? So these are the normal things actually that we do here in the UK, right? So what happens is if patient has got some problem, like they have got pain, they have got headache, they have got diarrhea, they have got constipation. So what happens is they might have Googled it because they might have problem for a week. So even we, if we have got any problem, we do check it online, isn't it? So they might also have Googled it. So if you ask about their idea, their concern, and the expectation from this consultation, you will see a lot of things will be clear. So when you're taking history and you're not very sure what is my diagnosis and you are blank, you don't know what to ask the next question. So what you do, you ask the idea. Please do ICE. Where I should do ICE? My answer is you do wherever you want to do. Can I do I separately, C separately, E separately? Yes. Can I do ICE more than once in a station? Yes, yes, yes. And please do ICE, and you will see the exam is going to be pretty easy. ICE is the best friend. Yeah, ICE is your best friend in your exam. All right. So if you get blank, please, please, please do ICE. That's really, really important. Another thing that you can do is you can do systemic review as well. So sometimes what happens is the diagnosis may not be very clear in front of you. So what you can do, you can do systemic review as well. For example, we had a station was on tiredness. Tiredness. It's a young female, say I would say 16 years, and she's feeling tired. Tell me what are your differentials, guys? Tiredness, very vague term, isn't it? Tiredness, 16-year-old female. I think you can give me n number of things, but I would like you to give me the commonest things. Give me commonest three, four things for tiredness. Anemia. Very well done, doctor. This is what I was looking for. Anemia, that's one. Yes. Give me any other differential for tiredness. Somebody said thyroid. Excellent. Malignancy, maybe yes, but I would say it's less common. Can I say that? Because if you see, like young patients, 16, malignancy is less likely. Yeah. Anorexia and depression, exactly. Very important, that one. A, B, C, D, E, that's the mnemonic you are giving. Like, see, anemia can be, sorry, tiredness can be because of problem in any of the system. Respiratory problem, cardiovascular problem, abdominal problem, oncology, infection, depression, psychiatry, musculoskeletal, anything, right? PMR, okay. Addison, okay. Hypothyroidism, hyponatremia, sleep problem, drugs, certain like citalopram, antidepressants. Okay, understood, understood. So the thing is, we did elaborate the tiredness. Patient is feeling tired for last couple of months and all. And anything else? No, doctor, just the tiredness. So how are you gonna go about it? Then you need to ask some associated symptom, and you need to try ruling out all these differentials as well, right? So chronic fatigue syndrome, less common though. Yeah, chronic fatigue syndrome is something like you have ruled out all the medical causes and patient is still feeling tired. It might be chronic fatigue syndrome. And one thing, Dr. Roy, for chronic fatigue syndrome, usually patient starts feeling tired after an event of a sore throat, right? So that can be the thing that you will look for in the history. Okay. Okay. So what I mean by systemic review, you can ask questions from all the systems. That will make your life easy as well in the exam. So you did elaborate the tiredness. What you did proper OD-para here. You did proper OD-para. Anything else? No, doctor, just the tiredness. So now it becomes very vague because you guys told me 10, 12 differentials. Am I going to rule out all 10, 12? Maybe yes, I don't know. So what do? You can do systemic review as well when the diagnosis is not very clear and the diagnosis might involve all the systems. So you can start like, for example, do you have any headache? No, doctor. Any vertigo dizziness? No, doctor. Any eye problem? No, doctor. Any runny nose? No, doctor. Any nausea, vomiting? No, doctor. Any chest pain? No, doctor. Any shortness of breath? No, doctor. Any diarrhea? No, doctor. Any constipation? No, doctor. Any tummy pain? No. Any UTI symptom like burning sensation, going to the loo more often? No, doctor. Any joint pain? No, doctor. So what happens is when you ask these many questions, what's going to happen? They will say somewhere, okay, I've got this problem, I have this problem as well. And it can actually lead to your diagnosis as well. So after tiredness, when I was asking or doing this systemic review, somewhere this patient said, doctor, I'm going to the loo more often these days. Okay, okay, okay. And then patient gave me the history of diabetes as well. It was type 1 DM. And later on I found out this is a DKA scenario actually. It was DKA. So that is, I mean, they started giving like a few months ago. This is a scenario they started giving because tiredness, young female, you have got n number of symptoms, n number of differentials, and it might be difficult for me to rule out all the differentials as well. So, what is the thing? What should be the criteria that I should? What should be my way of doing history? Is number one, do eyes. Number two, you can do systemic review as well. And if you do these things, examiner will be very impressed as well. Okay. So, guys, just one thing, put you in your mind. I'm not going to start my past medical history until unless I've got my diagnosis here, or at least my two top differentials. Remember, tell me more and anything else, life will be easy. Life will be easy in blood. Okay. Then we have got these questions from past personal social history as well. I'm not going to go in detail like previous similar episode, medical illness, medication, allergy, hospital stay, surgery, family history, smoking, alcohol, diet, physical activity, stress, drugs, sexual history, travel, occupation, living condition, driving. All these are important questions. But if you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, these are like 18, 19 questions. Am I going to ask all the questions? The answer is no. Please ask only 4 to 5 questions out of these 18, 19 questions. Which question you're going to ask, which question you're going to miss, you are the one who is going to decide it. Right? But decide. Only 4 to 5 questions you need to ask. If you're asking everything, it's difficult. then you won't have time for the management. Management is not just like telling the management to the patient. No, what is management? Management is involving the patient in the conversation. Management is making it two-way. Management is letting the patient ask a question. Management is making the patient talk. That is the management. Okay, so this is something very, very important. Who is a good doctor? A doctor is a good doctor if he asking less questions and is giving less medication as well, right? You won't become a good doctor if you ask all these 18, 19 questions. Then you tell me why I need a doctor. I can have a machine as well who'll ask all these questions. I can have a non-medical personnel as well. Maybe I'm not paying him enough and I can hire them. So we know as a doctor which question is important, which question is less important. And that's what you need to do in the exam, right? Then you can ask, is there anything else that I should know? So what happens is, if you're having a very good rapport with your patient and if they miss something, you can ask this line, is there anything else that I should know? They might give you something that might be helpful. All right. Patient's concern, make sure you're ruling out the patient's concern throughout. Yeah. Impact of the illness on the patient's life. That is very, very important. So for example, your patient is feeling tired. Doctor, I'm feeling tired. And this patient is saying, I'm feeling tired for last 3 months, doctor. So you can ask this patient how this tiredness has impacted your life in general. So this patient might say, oh, doctor, I used to help my kids in their homework and all. I used to play with them, but now I know when I go home, I just feel tired. I can't do anything. I really want to play with them. I really want to spend time with them, but it's not possible. It's affecting me mentally as well. So that is what I'm looking for. So impact of the illness on the patient's life is very, very important as well, right? So this is your psychosocial history. So do not miss that as well, right? So this is your data gathering. Now this side, what we have is the management. So after you are done with the history, is it necessary to summarize after history taking? I'll answer that in a minute, doctor. That's the next thing I'm going to explain. Just a sec. So after history, what you do is you do examination and initial investigation. So for example, we were dealing with a scenario. You tell me, the scenario was we have a young female patient. She was going to the loo more often. She has to sometimes rush to the loo as well, and she has to wake up in the night to pass urine as well. And sometimes she feels my urine is smelly. What do you think? What's happening? Can I say with this much of history, it's looking like UTI? Yes, you agree with me? Say yes if you agree with me. It looks like UTI. I'm 90% sure it's a UTI. Right, I'm not 100% sure. Let's make ourselves 100% sure. So in this particular scenario, patient is saying, I'm going to the loo more often. I'm waking up in the night as well, smelly urine, sometimes saying pain in the suprapubic area as well. Understood. Now, which examination you think you should do? Can I say I would like to do your general physical examination? What other examination you want to do? Can I say I would like to check your vitals as well? Yeah. And can I say I would like to do your tummy or abdominal examination? So that's what you need to do in that. Patient is a male or female. I said doctor, female patient, young female patient. All right. So these are the examinations I will do. Now, which initial investigation you think I should do, doctor? You tell me to confirm this diagnosis and what is the importance of which investigation? Which initial investigation I should mention? Tell me. Yes, urine dipstick. Yeah. Can I say that? Or maybe the blood work. This is what you need to do, right? Yes, urine dip and common blood work. Understand. Perfect. So what you need to do after taking history, you say you are talking to the patient that I'm going to do some examination. I'll do your general physical examination. I'll do vitals and I'll do your tummy examination as well. I'll be sending for routine blood work and I'll be doing urine dipstick test as well. So when you mention these things, maybe you will get some findings from the examiner. Examiner said, for example, patient has got tenderness in the suprapubic area. Another thing is urine dipstick. You have got leukocytes and nitrates, both positive. What does it mean? Can I say UTI? Can I say with 100% of thing that it is UTI? Yes. So this is what you need to do in the exam. So with the history, you will get a bit of idea, but then mention examination and investigations accordingly. Yep. Now answering your question, doctor, somebody asked me, Dr. Rekha, should I summarize? Now, how will I say here? Once I got these examination investigation finding, this is what I'm gonna say. So my patient name is, for example, Janet. So Janet, I've taken your history, I've done the examination and investigation as well. And all these assessment, I feel what I've come to the conclusion that you might be having a condition called urinary tract infection. Because you mentioned, I'm summarizing now, Dr. Rekha. So, because you mentioned you're going to the loo more often, you have got pain in your tummy as well, you are rushing to the loo, sometimes you have to wake up in the night as well, right? When I've examined, I found, yes, you're right, that there is some tenderness in this area of your tummy. And when I checked your urine, we found certain kinds of cells, like we say leukocytes and nitrates. They are kind of high in your urine sample as well. So, all these things are taking us towards a diagnosis, which is urinary tract infection. So what I'll do, I'll give my diagnosis and I'll justify my diagnosis. So disclose and explain the diagnosis and explain it with examination and investigation findings as well, whatever you have got. Right? So this is what I want you to do. Give your diagnosis and justify the diagnosis as well on the basis of your history, your examination, your investigation. That's what you do. Now, doctor, can I do summarization of the station somewhere in the middle as well if I want to do? So if I get blank here, what should I do? I told you to do eyes. I told you to do systemic review. Can I do the summarization of the station as well? Yes. So if you want to put the third thing, you can summarize the station as well. But you know, doctor, if you summarize again and again and again, it's not wrong, but it is time consuming. It's time consuming. So I would like you to summarize maybe here in this part of the station. That would be beneficial. But if you're doing it again and again, it's not wrong, but it's going to be very much time consuming. So be very careful. So my thing would be if if I'm stuck, I'm blank, I'll be going with ice. That is much, much better, right? Is it safe to just say routine blood or not to mention the component? Okay, good question. Uh, and also, and my question to you also, I'll answer your question, but you answer my question first. Should I say vitals or should I say blood pressure, pulse rate, temperature, SpO2? What should I do, doctor? Tell me. Then I'll answer your question. So you mean vitals enough? Okay. Then I would say routine blood test is also fine. But no, I'll give you one more trick here, tip here. Do this thing. For example, you're doing a station of thyroid, hypo or hyperthyroid. So tell me which vital you are looking for in hyperthyroid or hypothyroid station. Can I say looking for heart rate mainly? So what I would say, because I'm not an intelligent doctor, I'm a smart doctor. What I'll do, I'll say, I'm going to check your vitals, including your pulse rate. That's it. So examiner indirectly got the idea what I'm looking. If I'm dealing with a station which is postural hypotension, I'll say I'm going to check your vitals, including your blood pressure in standing and lying down position. So I'm not elaborating all the vitals. I'm just giving a bit of importance to that vital which I'm looking for in that particular scenario. Now, answering your question, should I say just the routine blood work or should I mention more components in it as well? You can do that, doctor, right? So it depends on what are you looking for. For example, patient said in the history, doctor, I'm having nausea, I'm having retching, I'm having tummy pain, I'm feeling a bit of tired, I don't feel like eating as well. So it's going more towards hepatitis. I'm going to do your blood test, routine blood test, including your liver function test. So just give a bit of importance to that liver function test. So examiner will be impressed. Examiner will understand what you are looking for. And that can give you an extra mark in itself. All right. So that is the main thing. Now, after this, what you can do, if there is any further investigation you have in your mind, you can mention that as well. Which further investigation? I mean, in any station, you want to do bronchoscopy, colonoscopy, CT, MRI, big investigation, you can mention it here. Now you go for treatment. You do symptomatic treatment and specific treatment. See, guys, don't underestimate symptomatic treatment. If patient told you in the beginning, I'm in pain, give painkillers. They said cough, give something for cough. They said nausea, give something for nausea. So what you do the symptomatic treatment. And then obviously specific treatment, medical or non-medical treatment. Now tell me, okay, Dr. What's the name? I think it was Dr. Sumer Khan. So for you, I'll say Dr. Medical or surgical or non-medical treatment. Which one? Should I do medical treatment first or non-medical? Again, it depends on the scenario. Which scenario you have got. So you can go for medical or surgical or non-medical treatment accordingly. And then decide admission. Do you want to admit the patient or not? If you want to admit, admit. If you want to discharge, discharge. And if you're not sure, then what? Then keep the patient in the observation. Call your seniors and they will be able to decide, should I mention the senior in all the station? Should I mention the senior in all the station? The answer is no. If you can mention, if you can manage the station on your own, then why I need the senior? But if I can't manage, I will definitely mention. So this is how you should go about it, right? So admission, then follow-up, OT-PT review, occupational therapist and physiotherapist. Occupational therapists are the one like they look after your house as well. If there is any change we need to make so that it is going to be good for you, that is usually done by the occupational therapist. So if you need to mention, you can. And then PT, physiotherapist. So if your patient needs any physiotherapy, you can mention that as well. Then follow-up and warning sign. I said it is the most important thing. Follow up and warning sign. Follow up and warning sign. Do not miss it. Follow up and warning sign. Red flag. Leaflets and pamphlets. You can always give leaflets to your patient. You won't be having that in the exam, but then you can mention that I'll be giving you some leaflets as well. You can read things in detail. That's it. So this is how it works. And patient will be asking the concerns throughout. So whenever they ask, answer it then and there. If you can't answer, so sometimes what happens is you're taking history and all of a sudden patient asks you in the middle their concern and you can't answer it then and there. So what should you do? For example, you're taking history and the history is going towards lung cancer. The history is going towards lung cancer. So what are you gonna do? And patient asks you somewhere in the middle of the station, doctor, is it cancer? So you can't answer it here because you have not asked all the questions and you're not pretty sure. So what you will say, acknowledge it. You will say, I can see, I can see you are worried about cancer. Let me assess you first. Let me do my history and then I'll examine you. Once I'm done with that, I'll be in a better position to answer your question. And then what you do, you move on with your history. So this is what you have to do. Refrain from saying yes or no. What you do whenever you get these challenging questions from the patient, you need to buy some time. How are you going to buy it? By acknowledging the patient's emotions. That is the main thing. All right. So, is it cancer? No. Yes. And then it's all messed up. So, what do you do when you get challenging question? You need to buy some time. You need to relax. Is it cancer? Wait. I can see you are worried about cancer. You know, when I'm acknowledging, I'm buying time, I'm thinking what should be my answer in the back of my head as well. So this is what you should do in the exam as well. Right? So acknowledgement is very, very, very important. And this slide, guys, this slide covers everything for you. The slide which you can see on your screen. If you can just remember it, life will be easy for the history taking. And in the history, tell me more, anything else. Tell me more, anything else. Patients are there to help you. But if you're asking leading question, if you're asking close question, they can't help you. So please, please ask open questions first. All right. Great. Now, if you do pediatrics, and gynae, these are the questions that you can ask. So, for example, you're doing pediatrics, you have presenting complaint, then you elaborate the presenting complaint, associated symptom, differential, past medical. But in lifestyle, obviously, you're not asking a 2-year-old, a father or mother of 2-year-old, you're not asking, do you smoke? Of course, child is not smoking, right? So what we have got this birth history. Birth history can ask how was the birth of the child, whether it was normal delivery or it was cesarean section. You can also ask any chance, any complication during the birth, right? Then you can ask about the immunization as well. If your child is up to date with the jabs, if your child is up to date with the immunization. You can also ask if there was any recent jab. Then we can ask about if you're happy with the red book or if you're happy with the development of your child. So that's the red book. Diet, you can ask how's the diet of your child. You can ask any recent change in the diet, for example, right? And that's it. right? And then any change in the urine, any change in the bowel, and who is looking after the child. So this is very important. In the UK, your child is government's child first, and then it's your child. So they are very sensitive towards children. So be very careful on it. Right. And then gynae history, same thing. But any female patient, if you get, keep these 5 P's in your mind as well. I'm not saying you have to ask these 5 P to every female. I'm not saying that. But if you get a female patient, just screen through these 5 P's in your head. Period. When was your last menstrual period? How many days you get the bleeding, right? If it is regular or not, and if there is any bleeding or spotting in between, right? If you are pregnant or not, if you are pregnant previously, maybe. So that can be important in some scenarios, pills, or if you are using any contraceptive method, right? That's important. Pap smear, we know it's a routine that we do. After 25 years, we do this pap smear. That's a routine cervical screening, right? At what age? From 25 to 49. If you know, we do it every 3 years, guys. From 50 to 64, this is done every 5 years, and more than 64, we don't do it. We only do if there are abnormal results previously. Understood. And then you can ask about the partner as well. So that is going to be maybe then sexual history as well. So that is something that you can do, right? Again, I'm not saying for everybody, but then you have to just keep these questions in your mind. Are there times we ask about period and contraceptive pills and obstetric history? Are there times? I think you're asking where exactly. So after you're done with present, past history, then you can ask this menstrual history as well, right? So yeah, I mean, around in the personal history or after past medical history, you can ask these questions, right? Again, I'm not saying you have to ask all these questions, but see which question is very important for me, right? So guys, till now we have actually talked a lot about data gathering, a lot about management as well. Now the question is, what comes under IPS? Yeah. So that I have put here. What comes under IPS? So number one is your active listening. How are you listening to the patient? That is really, really important. That's very, very important. Yeah. Uh, Active listening. So when patient is talking a lot, can you interrupt the patient? No. Can patient interrupt you? Of course. In many stations, you will see patient is interrupting you, but you make sure you're not interrupting the patient. So active listening is like, okay, right, sure, okay. So this is what you have to do. These are the active signs of listening. Body language, that's I told you how you're gonna sit, how you're gonna start the station. All things are very, very, very important. Yeah. So make sure your body language, positive body language, you have to show it's like I'm here to help you out only. All right. Third is your signposting. What is signposting? You know, when you're moving from one part of the station to the other part of the station, it's always good to give heads up to the patient that these questions are coming. For example, now I was doing this past medical history. Is there anybody in the family having any medical problem? No, doctor. And suddenly I asked, do you smoke? It's like a bit awkward question. Do you smoke? Oh, I mean, why did you ask straight away? So what you can do, you can signpost it here, meaning I'm going to ask you some questions about your lifestyle, about your smoking, about your alcohol, because this history might be related to your case and will help me in the management plan. Tell me, do you smoke? So this is what the signposting is. For example, I asked you to do systemic review, but you might be thinking, how should I just start it? So what you can do, you can just signpost it saying, now, John, I'm going to ask you some yes or no questions to cover all the systems, just to make sure I'm not missing anything. And then start. Do you have any headache, any dizziness, any chest pain, any shortness of breath, any diarrhea, any constipation? And that's it. You already mentioned I'm going to ask you some yes or no question to make sure all the system and everything is fine with you. Just signpost it. Signpost doesn't mean you are taking consent. Don't say, can I ask you this question about your lifestyle? No. Say, I'm going to ask you some questions about your lifestyle. So I'm just preparing the patient. I'm just giving heads up to my patient that these questions are coming. All right. Involve the patient in the management. Management is not like you're saying things to the patient. Management is involving the patient in the management. Summarizing, yes, absolutely you can do, but don't do it quite often. If you do it quite often, the problem is the time. But when you give the diagnosis, you can definitely do it. Chuck and check, meaning when you give the information, you give in small chunks and then you check the understanding of the patient, whether they understood it or not. You give the information in small chunks, then check the understanding. Small chunks, check the understanding. That's what you do. Ice, I can't stress it enough, guys. Ice, 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 ice. Very important. Where I should do ice? Wherever you want. Right. Otherwise, definitely before the diagnosis, yes. Otherwise, you do wherever you want. You got stuck in the history, wherever, just do eyes. It's your best test friend in the exam. Respond to the cues. Respond to the medical, non-medical, respond to the verbal, non-verbal cues. That's very important as well, right? So respond, right? Patient is shaking his leg. I can see you're shaking your leg. Is everything all right? So this is very important, right? Guys, trust yourself. That's really important. Trust yourself in the exam. You have read enough. You are a doctor, so behave like one in the exam as well. Okay. Use small sentences. Whenever, see, all of us, we have given OET or IELTS, right? And I think many a times our instructor for OET and IELTS, they say, use complex sentences, then you're going to get high score. Here, I would say use small sentences. Even if you're making a grammatical mistake, nobody bothers. As long as you're able to make the other person understand what you're saying, you're doing good. That's it, right? Practice in front of the mirror. That's going to help you a lot, a lot. You may underestimate this thing now. Do it for 2 weeks and then you will see the difference in you. The smile doctor that you are having will not look like a fake smile. You will be able to improve on that as well. Record your consultation as well. So whenever you're doing the practice in front of the mirror and all, record it as well. See one station and record it, and then listen to it, and then you will see, okay, what I'm doing good, what I can improve on. That's the main thing. You have to be mentally strong as well. You have given lots of exam in your life, right? So you have to be strong. You know it. You got it. Be confident. Under overconfidence, both are not good. Be confident. The thing is, they have asked you a question, you don't know what you can say. See, I don't know. Just be honest and be confident. Very good question that you asked me, but I'm not sure about it and I don't want to give you any wrong answer. Let me confirm it with my seniors and I'll get back to you. Say things with confidence. What happens sometimes, you answer the patient all the questions and you're doing very good consultation. All of a sudden, a question came from the patient side and you don't have the answer. And what you do then? Just then start looking here and there. Don't do that. If you don't know the answer, just say, I don't know what's wrong in it. Right? The reassurance is very important. So many stations, if you see their reassurance station, give them reassurance. When you give the reassurance, your voice, your body language should have confidence as well. Tell them there's nothing wrong. You're gonna be all right. So give the reassurance properly. But when you give the reassurance, give them the warning signs as well. There's nothing to worry, but if any of these symptoms appears, make sure to bring them to the hospital. All right. Trust your language skills. All of you have passed English exam. That's why you are giving clap too. All right. Relaxed mind can do wonders. So relax. That's very important. I don't want you to relax too much because in exam, obviously, a bit of stress is okay, but it should not be that much that it affects your confidence. So be careful on that part. So these are very important pointers, and these are your interpersonal skill points. Yeah. Okay. Now, I'll show you like 2 slides on teleconsultation as well, and then we'll go for the break as well. So, teleconsultation. First of all, who is calling? It's you as a doctor calling the patient or patient calling you. What do you think? You calling or the patient calling? Tell me. So, we, doctor calling, doctor calling, doctor calling. Okay. I would say it can happen both ways. Mostly it is us, doctors calling. So what happened is patient, they actually book the appointment, like they call the surgery and they book the appointment. And at that particular time, doctor is gonna call. Understood. But sometimes it is an emergency as well. You might be calling directly to the A&E as well. So it might be a triage care call, and you directly get the call as well, right? So mostly, yes, agreed, it's doctors we are calling, but sometimes you might have some in some station where patient is calling you as well, but mostly it is doctors calling. Yeah. Okay. So guys, what is emergency number in the UK? Emergency number? Tell me. Emergency ambulance number? Understood. Triple nine. Okay. My next question is, guys, what is a non-emergency number in the UK? Anybody? Non-emergency number in the UK. So when your problem is not very much emergency, but there is a problem, obviously. So you have a non-emergency number as well. You can call them, and maybe in a few hours they'll put you in contact with the specialist on that particular field according to your symptom, and they might give you the medication. So yes, you're right. It is 111. Right. So emergency is 999. Non-emergency is 111. Okay. So make sure when you're doing the teleconsultation, how many stations you're gonna get? One to two, not many nowadays. Yeah. So first thing is talk to the patient if possible. Talk to the patient. So you have to see the task carefully that you're talking to the patient only. If the task says you're talking to somebody else, talking to the mother or father or talking to the son, daughter, then it's okay. Otherwise, you have to be very careful. If you're not talking to the patient, you need to check if there is a consent written in the question or not. Confidentiality consent is the most important thing. Appearance. Check if the patient is depressed, anxious, because these things can be missed because of visual absence of visual cues. Now, somebody asked me the question about domestic violence. I know it's going to be very challenging, doctor, but you need to check few things with the voice of this patient. The tone of the voice of the patient is going to give you a lot of ideas, right? And check if they are in suitable place to receive the telephonic call. So whenever we book the consultation, so our staff, they book the consultation that doctor is going to call you in this much of time. Maybe they're going to call you between 9 to 11 in between. Like we're not going to say, okay, we're going to call you at 9:30, 9:40. No, we give them the time frame that I'm going to call you, or the doctor's going to call you between 9 to 11. So maybe you called the patient say at 10 o'clock. So you need to be very careful if they are in a suitable place to receive the call. Maybe that time when you called the patient, they're driving. So do you think it's a good time to talk? Not really. So that's why you need to be very careful about this as well, if they are in a suitable place to receive the call or not. Yeah. So with this, I'll put this slide actually for teleconsultations. So you always introduce yourself, you identify the patient as well. You ask the patient if it is a good time to talk. I just want to make sure my patient is in proper place, is not driving at least, yeah. Whenever I confirm the identity of the patient on the phone, I have to be very careful. I confirm the name, I confirm the date of birth or age, and I confirm the address as well. When you enter into the cubicle, you will be given the same task which you have read outside. In teleconsultation, you will have some extra information, mainly the address of the patient as well in the cubicle. So you'll have the address of the patient as well in the cubicle. So you need to confirm three things, guys. You need to confirm the name, you need to confirm date of birth or age, and you need to confirm the address as well. When we're doing in-person consultation, we do not confirm the address, but in tele, you need to. You need to confirm three things: name, age, address. Why address we confirm? So that, for example, you're talking to the patient, and uh, all of a sudden, this is like an emergency situation, and patient is not listening to you at all, and you're saying hello, 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 nobody's responding. So maybe it's a patient has collapsed. So at least you have the address of the patient, so you'll be able to send the help as soon as possible. All right. Do we ask the patient's name first or intro ourselves first? To be honest, it doesn't matter much, but I would recommend you to ask the patient details first. Okay, but doesn't matter much because patient himself, herself has given us the detail. That's why we're calling this patient. So it should be the patient who's picking the call according to us, right? So I would start like, Hello, am I speaking to Mr. Stanley Smith? Yes, Stanley speaking. Hello, Stanley. This is Ankur, one of the doctors calling from this department. Could you please confirm your age? Yes, I'm 25. Could you please confirm your address as well? Yes, this is my address. Is it a good time to talk? Yes. Are you able to hear me clearly? Yes. Are you able to see me clearly if it is a video consultation? Yes. Tell me, why did you book this appointment? So this is how you're gonna start the station, right? Golden minute. What I mean by this golden minute? See, first minute of the station is the golden minute. What we mean by that? See, golden minute is we are, we're getting the free information. So you just ask the patient, okay, tell me more about your pain or how can I help you? And patient started giving you the history. They said a lot of things to you. So you're getting free information. That's why I say first minute is golden minute. Make sure you do not interrupt the patient. Always take targeted history. Don't ask too many questions, just the targeted questions you need to ask, right? Social history, psychosocial history is very, 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 very important. Because sometime on the phone, you have decided to give the medications to the patient. Now, how this medication is going to reach to the patient, that's very important as well. Are they going to come on their own to take the medicine? Or if they're not in a situation to come to the clinic or to the pharmacy, then ask who else is there in the family. Maybe they can bring the medication on their behalf. That's really important. And don't miss red flags and differentials. In terms of IPS, guys, in teleconsultation, we can't do much. Just the warmth in the tone of your voice is your IPS. That's it. They can't see you. You can't see them. So there's no facial expressions and all that you need to be worried about. But your tone of voice should be good. I do not interrupt the patient. Just be very, very careful. Now, in terms of management, guys, can I do the investigation? Yes, I know on telephone we can't do it, but if you feel like doing investigation in any patient over the phone, what do? You can arrange a face-to-face assessment for them in the GP, or you can arrange a face-to-face assessment in the hospital as well. So do not hesitate. All right. We can give telephonic advice. We can give online information leaflets as well. So on the phone, you might be thinking how I'm going to give the leaflets and all. It is doable. It's not difficult. It's not difficult at all. So what you can do in terms of it, we can tell the patient that I'm going to send a leaflet to you. So we can send a link to the patient's phone and they can read about their leaflet as well. Right. So we can organize the test in the GP or in the hospital. GPs, they do home visits as well. So in any case, if you feel like patient is bedridden, they cannot come to the clinic. So we may be going to the home as well. All right. Sometimes when you see the patient and the history they are giving is very tricky. The history they're giving is I was having chest pain, which is going to my arm and to my jaw. But right now I'm feeling okay. Right now I don't feel I have any pain. But it was going to the arm, to the jaw. What is it? It looks like stable angina. Do you think it's serious? It can be serious, yes. So what we need to do? We need to urgently refer this patient to the A&E. So tell this patient, I'm going to send the ambulance, and what you're going to do, you're going to come here, right? Collecting prescriptions. So over the phone, you have decided that I'm going to give antibiotics to this patient. So how this antibiotics going to reach to this patient? Do this patient has to come to the clinic for the antibiotics? The answer is no. If he has to come to the clinic only, then what is the point of doing teleconsultations, right? So what happened is everybody is registered with the GP, but they're registered with the pharmacy as well. They're registered with the pharmacy as well. So what we do, we tell the patient that I'm gonna send this prescription to that pharmacy. You go and collect it. That's how it works, right? Don't miss the follow-ups, warning signs, safety netting, ensure everything is in place, and tell the patient do not miss the red flags for sure. That's it. Right? So that's teleconsultation. Nothing much differently you have to do. It's same as in-person consultation. Just remember you're confirming three things. You're confirming the name, age, and address. These three things. So that's really, really, really important. Okay. Right. So history taking. So what are we doing? If I will be very straightforward. So you have got the presenting complaint. Then what you do, you elaborate the elaboration of presenting complaint. Then you have got associated symptoms, and you have got some important differentials as well. So presenting complaint is elaboration of presenting complaint, associated symptoms, or your differentials, right? And then you have got your past medical, your personal or social history. A very quick one, this has to be, right? And make sure you don't miss your eyes and don't miss your psychosocial history. That's it. And then you will conclude with examination and investigation. So that's your data gathering. So presenting complaint, history of presenting complaint, elaboration of it, associated symptoms and differentials, right? Then quick PMH, personal, social, ICE and psychosocial, whom you are living with, how's your mood, is everything all right? These questions are very important as well. Okay, and then that's it. And in the history, please do not miss two questions. These are tell me more and anything else. And later, please ice it up. Right, so that's your introduction, I would say. Thank you. So that's the introduction.